Hello, my name is Bill Temes and I'm with the North American Institute faculty. We're here to discuss a case of a motor vehicle accident individual who showed up and came in approximately 5 weeks post motor vehicle accident, where she was hit on the passenger side. She was the passenger, and her head did hit the side window, and she presents today with complaints of some upper neck headache pain, some lower cervical pain, some pain into the face and jaw, and intermittent ringing in the ear on the right side. The purpose of our evaluation is going to be to make sure that she's safe for treatment, and also to distinguish between whether or not we have an upper versus a mid to lower cervical spine problem, and then how to differentiate between, if it is an upper cervical problem, whether the issue relates to the upper 2 segments or the C2-3 segment. Biomechanical assessment of the upper cervical spine is necessary when a patient presents having had an injury or trauma to the head or face and presents with trigeminal symptoms or not. For an individual who presents with trigeminal symptoms who have not had trauma, or for an individual who has no trauma and has no symptoms necessarily at rest, but when they are rotating their head to one side or the other with significant loss and they have the onset of symptoms. When we talk about trigeminal symptoms, we're talking about pain that can occur in the face, in the jaw, in the ear, in the eye, and other issues relating to dizziness that they might have, tinnitus that might be present. They may have a feeling of anxiety, and these are the individuals who we want to make sure that we do a thorough assessment. And the history is obviously most important to determine just where we're going to start this assessment. For someone who's less than 6 weeks who comes in with this patient presentation, we're going to first consider whether or not it's necessary to do a cranial nerve screen or not. If we're going to do a cranial nerve screen, we would complete that before going on to what we would consider our acute upper cervical scan. The acute cervical scan, again, is to identify whether there's any red flags or yellow flags that might be indicative to determine whether or not the person needs to go back for further medical assessment. This is going to include active movements with no hands-on, no overpressure, no resistance given to the spine, to see the willingness of the individual to move through range of motion, and to identify whether there's any signs or symptoms that would preclude going any further. So with that in mind, what I'm going to have Christy do, if you'll just turn towards me, Christy, I want to be able to observe Christy's face and certainly be able to observe her eyes in particular. I'm wanting to know of any cardinal signs that she might have with movement that we do, or any worsening of any symptoms that she has that she presented with at first. Again, remember, the cardinal signs are going to be those symptoms relating to any loss of balance without any loss of consciousness, any quadrilateral paresthesia, any lip or tongue paresthesia bilaterally, and also whether or not she has any nystagmus that's present with any neck movements. I'm just going to ask you to go through some different movements from side to side. I'm not going to place my hands on your head. I just want to see how you feel with motion, and I want you to let me know if anything gets any worse for you in any way, shape, or form. Okay? So I'm going to first ask you to turn your head, rotate your head to the left, good, and back to the middle, and then to the right. Rotation is obviously a very important movement to observe, because this is one of the key motions that we'll be able to identify for vertebral basilar insufficiency. Also, it gives us an idea about whether or not she's willing to move. If she was unwilling to move her neck in any in the direction, then my thoughts move to the possibility of a fracture that might be present. I'm now going to see whether or not you can bring your ear down towards your shoulder. Can you do that? Right. That's good. Come on back to the middle, and just wherever you're comfortable to the right. That's good. And come on back. Again, most of the side bending motions will will help us determine what's happening more towards the mid and lower cervical spine. We want to kind of get a sense of how she moves through that. And then I'm going to ask you now to go ahead, and I want you to see if you can tilt your head back for me. Extension, again, is one of those motions, and come on back. One of those motions that are important to identify, given that it's another vertebral basilar insufficiency motion. And also, if someone's had significant trauma to structures on the front of the neck, such as the anterior longitudinal ligament, or individuals who might present with even rim lesions. These are going to be identified with motion in this direction. And then just bring your chin towards your chest or Adam's apple. And as she flexes down, come on back. I'm observing for the way she moves to make sure that she doesn't try to flex from the mid to lower cervical spine as she extends the upper cervical spine as a method of trying to keep her head in a good position. And also I want to get a sense of whether or not she has any problems with movement or any increase in symptoms that may be indicative of cord-like signs, which again would mean that we might want to check to see if she does have quadrilateral paresthesia. We might do another test, which is what's called a sharp purser test, to see if those symptoms are removed when we bring her back. So a sharp purser test, quite simply, is taking one hand and placing it on the C2 process, spinous process posteriorly. Bring your head down forward. If she was symptomatic like this, C2 is fixed, and then I'm going to just take the occiput and the C1 and move it back straight forward back onto the C2 to see if that does reduce her symptoms. If that were to reduce her symptoms, then this is someone obviously who needs to be looked at for other types of pathology, including cord compression and or instability in the upper cervical spine. The acute scan will be completed with compression and distraction of the cervical spine, again looking for any cardinal signs and symptoms. I'm going to, Christy, give you a little bit of compression on top of your head and then do a little distraction. Again, if anything comes up, I want you to let me know about that, all right? So I give very minimal amounts of pressure directly down. This will be 3 to 5 pounds of pressure, very gentle. I'm watching again for any other signs and symptoms. And I'm going to give a little bit of distraction here. Let me know if anything bothers you here. Good, no problem with that. And relax. Good. This would complete the acute cervical scan. The next step to which will be, we would move into our our ligamentous stress test of the upper cervical spine, followed by assessment for vertebral artery symptoms, signs and symptoms, which is an ongoing process. And then also we will determine whether or not if the person has dizziness, lightheadedness, we would do a assessment to determine whether or not we can differentiate between cervical problems causing this or something from higher centers. As we've discussed in the 500 and 600 series classes, the scan of the upper cervical spine and neck are going to be done first with a detailed observation of the individual, looking for any identifying marks, potentially a fracture being raccoon eyes and or a battle sign, which is a bruising on the mastoid process, and then doing any other if we do see these, we then send the patient out for x-rays if they haven't had x-rays. Christy has had x-rays in the emergency room when she went, and those were clear, those were fine. In the individuals that require cranial nerve screening, that would be done. We would also do an acute cervical scan looking for any red or yellow flags or cardinal signs or non-cardinal signs with movement, active movements with minimal hands-on. And then we would do a craniovertebral ligament stress testing, and then we would also always be observing for any signs and symptoms of vertebral or carotid artery dysfunction, and then also looking for any signs and symptoms that would indicate that we need to go further into assessment for dizziness and lightheadedness. Having completed these series of steps to clear the acute individual, we would then determine whether or not we can continue to go on for a more detailed biomechanical assessment, looking specifically at determining whether or not the problems exist between C2, 3, or AA and AO joints. And this will be done in such a manner where, Christy, I'm going to have you turn towards me on the side here. Christy came in with symptoms with right facial pain and headache pain. And what we're going to do is we're looking for reproduction of symptoms on that right side, those usual symptoms she has. We know that these symptoms were documented with her acute scan with turning her head to the right. So what we're going to start with first to distinguish between C2, 3 and the upper cervical segments is I'm going to ask you first, Christy, to side bend your left ear towards your shoulder and determine whether or not there's any pain with that. That should not necessarily create any pain unless there's a problem. Do you have any problems with that? So with C2-3 side bending to the left, we know that rotation and side bending at C2-3 go together, so there shouldn't be any reproduction necessarily of her symptoms to the right. However, if she was symptomatic, we should consider that the AA or AO joint, which the motions that go along with the left side bending are right rotation. If symptoms come on with the left side bending, we would consider that probably the AA or AO joints are involved. Come on back. If we identify the C2-3 as being the primary culprit, then what I'll have Christy do is side bend her head to the right, and then we would expect pain to be reproduced. And then if she rotates her head to the left from that position, we probably would identify the problems being more at the bony facets. And then if not, we come back to the right, and if that's a problem, then probably the joint capsule is more the problem rather than the facet joints are. Okay? If the problem is considered to be one of the upper cervical segments, AA or AO, the way we can identify the differences between the two there is we identify C2 as being a fairly mobile bone. I'm going to ask Christy first to turn her head to the right, and she goes as far as she can there. If I then come to the atlas, C1, and I hold her head in position here, I then take the C1 and I rotate it to the left. If that makes her symptoms worse, then we would suspect that the AO joint is involved. If it makes her symptoms better, we would suspect the AA joint is involved. AO joint, as we rotate the atlas to the left, continues the rotation from the bottom up. And if that made her pain worse, then the AO joint would be the one that is the significant one that's involved. And if it makes the pain better, then we suspect that the AA joint is probably the one that's the culprit. We can also take the atlas and rotate it to the right, where if it was the AA joint that's the problem, that would have made that worse and lessened the possibility that it was the AO joint, which is actually having a reduced amount of rotation at that segment.